Okay, I'd like to welcome everybody. This is our Coastal Hospice's third lecture in our Beyond the Basics series. And today we want to look at non-pain symptom management. A lot of terms get tossed around some people look at pain as just physical pain. Sometimes pain gets talked about as, and a lot of the hospice literature, as total pain. And total pain could certainly be nausea, dyspnea, psychosocial or spiritual symptoms. So sometimes pain has a broader term than just the I hurt kind of physical pain. And we've already devoted one whole lecture on the issue of physical pain. The other thing that often gets confused is the difference between pain and suffering. And I've seen a lot of different interpretations of the differences between those two. Probably the most interesting, I think, is the Buddhist interpretation. A couple years ago, the Buddhist chaplain from Harvard spoke at Salisbury University, and his subject was pain and suffering. And he said pain is an unavoidable consequence of life. Suffering is a choice. And the example he gave was an argument. So if we have an argument and we're both passionate about our positions and we're shouting back and forth, well, we're experiencing pain, and that's unavoidable. But then we get in our cars and we drive home and we're reliving that argument over and over again. That's suffering, and that's a choice, and that's something we can, and the good news there is you can choose not to suffer. So those terms get tossed around a lot. What I'd like to do today mainly is to look at a methodology for dealing with symptom management, and then just sort of have a potpourri of different symptoms and work through how we deal with them. Point to make here is one of the unrecognized benefits of hospice care is that hospice patients actually live longer. So if patients with life-limiting illness come under hospice care and we can serve them for at least a week, we're actually going to prolong their lives, and that's something that's not well appreciated. Recent data which was published in the Journal of Pain and Symptom Management last year, which is a big Medicare review. Every Medicare patient has a billing record, so there's a lot of data about every Medicare patient. Of course, we know their diagnosis, we know how long they live, and we know whether or not they become a hospice patient. And matching patients and those that have come under hospice care with the same diagnosis, same age, live substantially longer. Couple reasons for that. One is we improve their physiology. Patients who have uncontrolled physical symptoms are kind of that fight or flight type of mode. Catecholamine levels are high, adrenaline levels are high. Patients' pulse rate, blood pressure is high. And if you're being chased by a bear, that's a very effective way to be. Although you're not going to outrun them, but at least it gives you a few more seconds of life. But it is not a good way to be long term. And if we can improve patients' physical symptoms, we can reduce their catecholamine levels, get their pulse, blood pressure, and everything down. And that probably contributes to prolongation of life. And this is probably the closer truth here, but this is something that's not very popular. I kind of duck when I show this slide to my medical colleagues, is that we protect patients from unnecessary medical treatment that actually shortens their life. And there's been a lot written about this. Dr. Wenberg from Dartmouth has been a voice in the wilderness probably for 20 years, talking about how we can make people live longer if we protect them from futile therapy. Peter Orzog is currently the head of the Congressional Budget Office. He's actually been on television several times recently regarding our current financial crisis, but he speaks a lot about health care as well. And he's written a lot both in the scientific journals, but also in New York Times, Washington Post, that sort of thing. Big review article in New England Journal of Medicine last year that covered this subject. I was getting a haircut a few months ago and was sitting in the barber chair reading the Baltimore Sun paper, which is the only time I get to see the Sun paper. And there was a big op-ed piece about how futile care shortens people's lives. Great book if you haven't seen it. It was been on the bestsellers list. It's by Shannon Brownlee. It's called Overtreated, and it talks about how probably a third of all healthcare is futile. So that's something I think it's going to be very important as we're discussing nationally now with our election season, how we want to reform our healthcare system as well. Well, basic principles of how we manage symptoms at end of life. We want a directed physical and history. We want to think about the causes that we might be able to treat. Classic example is we had a patient admitted to hospice at the lake not too long ago for uncontrolled agitated delirium. Patient had been at a large hospital for a couple weeks before that. Obvious on physical examination, this male patient had a 20-week uterus palpable to his belly button, so his bladder was the size of a basketball. Foley catheter drained his urine, agitation immediately went away. And that's something that comes up surprisingly often. So looking for treatable causes for uncontrolled symptoms. Work as a team, and remember we project a lot of non-physical symptoms as physical symptoms. Patient will say, I'm short of breath or I'm in pain, when really the problem is a psychosocial or a spiritual issue. So we want to work and use all the members of the team. We want to communicate effectively what the problem is, why we think our recommendations are going to help, and we want to follow up. It needs to be a continuous loop. What worked, what didn't? If it's not working, what do we need to change? Urgency dictates speed. A mild symptom may just need reassurance and explanation for what's going on, and explain what we're going to do if things do get worse. Moderate problems need treatment and follow-up, hopefully generally by an oral route, but patients need to know what the backup plan is as well. Severe distress is an emergency. Drives me up the wall when we've got somebody at end of life and they're in the hospital and they can't get their pain medicine for 4 hours because it's by the clock, and the patient's sitting there staring at the clock. Well, that's absolutely unacceptable. One of the national goals of hospice is comfort within 48 hours. My position is comfort before the sun sets, so we need to rapidly escalate medications until we achieve comfort. If we're aggressive in symptom management, we can avoid transfers, whether it be transfer to our inpatient facility or a panicking family that calls 911. And communication is essential, particularly as the patient is close to death, and they need to understand that some of the symptoms that are being experienced are a natural progression of the dying process and doesn't necessarily need aggressive intervention. What are our goals? Our goals are to improve their quality of life, to use our medication efficiently, to minimize their side effects, use appropriate routes of administration, make the dosing simple, and anticipate disease progression. The fewer medications people are on, the simpler the schedule, the less likely we're going to have drug-drug interactions, the less likely we're going to have drug side effects. And disease progression is something that needs a lot of counseling with families, and they always want to blame it on anything but the disease. So that they need to understand that it's not that they're overdosed on their medication, it's that it's the cancer that's causing the patient to get weaker. Always a good idea to add choice, not to take away choice with patients and families. Obviously, we do treat a lot more than cancer patients, but I wanted to use this particular example. This is a list of issues that patients with cancer have, and their biggest complaint is fatigue. Pain is third on the list. On the other hand, when you interview the families, they have a different list that they consider important, with the decline, the weight loss, and the weakness top on the list. Sedation, loss of appetite is their big issues. The patient is the one with the disease, but obviously we have to treat whole families, and so you've got this different agendas between patients and families, and we need to bring them together. The sedation, the anorexia are symptoms of progressive disease, and those obviously cause more stress with families than they do with patients. All right, let's just sort of start running through a whole sequence of various symptoms. Nausea and vomiting is something we deal with a lot. There's a whole list of possible causes. The most common one we deal with is a chemoreceptor trigger zone in the brain. This is a constitutional effect of metastatic cancers and other issues. Gastric stasis, vestibular problems, anxiety, anticipation, increased intracranial pressure, gastric irritants, and bowel obstructions are all possibilities, and we'll take these one at a time. Chemotherapy trigger zone, the key is that they're nauseated all the time. And that's what we see the most. The drug of choice is Haldol or haloperidol. Very effective. Sometimes a hard sell, because families know, well, that's a crazy pill. Well, I'm not crazy, I'm just sick to my stomach. Extrapyramidal side effects are pretty rare at the end of life. The main problem why Haldol lost favor as an antipsychotic drug is these dystonic reactions, the lip smacking and tongue protrusion type of things. You generally got to be on the medicine for a few years before you start to develop those symptoms. So it's rarely a concern at end of life. The problem is if you start getting those dystonic reactions, they won't go away, even if you stop the medication. But almost never do we deal with that in the hospice setting. It is dopamine mediated, and so it's you might, in occasional, and I've seen it a couple of times in 3 or 4 years, where you start to get Parkinsonian type symptoms in patients that don't have Parkinson's disease. The biggest thing is there's a resistance to movement and rigidity, and so it's a good idea when you've got somebody on Haldol just to do some simple range of motion with them once in a while. And if you're starting to get stiffness and resistance to range of motion, and particularly this cogwheeling, whereas you try to straighten out the arm, it's just kind of like there's a cogwheel clicking, that suggests that they're probably getting Parkinsonian symptoms and that they need to come off the medicine. It is contraindicated in patients who already have Parkinson's disease. The other anti-nausea medicines, Compazine, Tigan, Phenergan, are really marginally effective, and we use those sometimes. A lot of doctors really like them. They're not nearly as effective as Haldol, and again, these are people at the end of their lives. We need to get their symptoms under control pretty rapidly. These medicines also tend to be sedating, whereas Haldol is not non-sedating. So for all those reasons, they're not nearly as good of choices. Ondansetron, brand name Zofran, was developed to protect patients getting cytotoxic chemotherapy from the nausea and vomiting of chemotherapy. You give it IV just before you give chemotherapy. Very effective in that setting. Anesthesiologists have found that it's also very effective for the nausea associated with anesthetic agents. Not nearly as effective as Haldol, interestingly, in the nausea that we see at end of life. It's also extreme, and there's a whole bunch of related agents as well, and they're all very, very expensive. And so we have to be cost conscious as well. Gastric stasis. This is patients that have nausea and vomiting a couple hours after eating, or nausea and vomiting that occurs only at night. The most common setting here are diabetic patients. Diabetics have problems with small blood vessels, and one of those is the small blood vessels around nerves. And that's why diabetics have peripheral neuropathies, and it's also why they have gastroparesis. Gastric stasis is the little nerves in the autonomic system that innervate the stomach don't work right. The stomach doesn't contract. And so if you've got a patient that's nauseated, again, after eating or night, and particularly if they have a history of diabetes, even if their diabetes is well controlled, suspect that gastric stasis is the problem. The drug of choice here is a prokinetic agent. Reglan or meclopramide. Reglan is called the digitalis of the gut. It makes the gut contract harder. Had a patient last week at Hospice at the Lake. It was a diabetic. People didn't make much of the diabetes because the diabetes was well controlled. Patient had been on Haldol, wasn't controlling the nausea. Dr. Warris switched the patient to Reglan. Nausea went away within a day. So this is easy to overlook. Some nausea is related to the inner ear. And the key thing here with vestibular problems is the patient has vertigo. Patient perceives motion. Either everybody standing around the bed is swimming around them, or everybody around the bed is staying still, but the patient feels like they're spinning around. So that sensation of vertigo needs to be treated differently, and antihistamines like Benadryl works very well, cheap. Cerebral cortex agents. When I was in the Navy, as an oncologist, I treated the cancers of young men, which is kind of who most of our patients are. And the two cancers of young men are testicular cancer and Hodgkin's disease. And we treated Hodgkin's disease patients with nitrogen mustard, and we treated testicular patients with cisplatin, both of which are drugs that are terrible for causing nausea and vomiting. And back then we didn't have any good anti-nausea agents, although the guys would go in the bushes and smoke marijuana before they'd come in for their chemotherapy treatments, and that actually worked pretty well. But they had a lot of problems with nausea and vomiting. And I treated one young man for testicular cancer, and he was cured, and I hadn't seen him in over a year, and he was coming back into the Bethesda Naval Hospital to visit one of his buddies, and I passed him in the hall. He took one look at me, he dropped to his knees, and he vomited, which is a great way to feel for curing somebody. But the point being is it brought back the memory, and so that kind of anticipation can trigger nausea and vomiting. Patients may manifest just their general anxieties at end of life, and so a chill pill like Ativan might be a good choice for them. Patients who have brain metastases from cancers, which is something we see fairly commonly, and are nauseated, virtually 100% of them have increased intracranial pressure from the metastases in their brain, and that frequently causes nausea. The treatment is to decrease the intracranial pressure, and dexamethasone is the drug of choice for that. Gastrointestinal irritation. Patients may be taking NSAID drugs like ibuprofen for mild pain, and that can cause gastrointestinal irritation. And one of the proton pump inhibitor drugs work very well for that. There's a whole host of these products, and our scumbag pharmaceutical industry keeps bringing one out after another so that they can charge more for them. They're all pretty much equal, and Prilosec OTC is currently the best value, so that's generally what our pharmacists recommend. Bowel obstructions, fairly common, particularly with people with intra-abdominal cancers. Bowel obstructions can be partial and intermittent. The clues to a bowel obstruction: the patient has a lot of abdominal pain, nausea, and vomiting. They have a very abnormal physical examination, often with a rock-hard abdomen. And they may have a feculent odor to their breath, or they may actually throw up material that looks feculent. And sometimes these bowel obstructions are partial and intermittent. They'll seem to be completely obstructed, then they get better for a few days, then it comes back. A very nice way to treat that is with Vaseline balls. And you have to kind of get your mind past the negative mental images of this. But what we do is, and actually we have our volunteers, they will roll up petroleum jelly in little tiny balls, maybe pea-sized or smaller than that, and dust them with either powdered sugar or cocoa, and then on a tray freeze them. And the patient swallows one of these whole, and that's important. You swallow it whole, you don't chew it. like 1-3 times a day. It does a couple things. Number one, it increases peristalsis, and the other thing it does is it kind of greases the intestine from the inside out, and often you can help delay or prevent progression to a complete bowel obstruction by using these Vaseline balls. It's interesting, this was a kind of grassroots development. Hospice nurses had kind of figured this out on their own and had been talking to the doctors who told them, you're out of your mind. But after a while, people started seeing that it works, and it's now gotten more into the mainstream literature. Complete bowel obstructions can be either high, meaning the stomach or the proximal duodenum. Most bowel obstructions are further down. If the patient has a high complete obstruction, we're really not going to make them comfortable unless we can vent their stomach and get the gastric juices out. I hate nasogastric tubes at end of life because I think they're demeaning and they're very, very uncomfortable. So if I see a patient at the hospital that has a complete high bowel obstruction, they're talking about transferring them to hospice at the lake, I'll ask them to put in a PEG tube before we transfer the patient. Not for feedings, but just to put it to drain or to suction so that we can keep the stomach decompressed. Most bowel obstructions are low. The pain and the nausea is caused by peristalsis coming up against a complete obstruction, and the way to deal with that is to decrease the peristalsis as well as giving pain medications. And so using anticholinergic drugs like atropine or a scopolamine patch are very effective, and usually we can manage these people without nasogastric tubes. Constipation is a common problem. All hospice nurses have a secret special certification as certified constipation specialists. Everybody on narcotics is going to get constipated, and we need to treat them all. And I tell patients, I don't care what your bowel habits were. I don't care if you only move your bowels on New Year's Day once a year. From now to the rest of your life, you're going to have a bowel movement every day. And some people will fight you for that because they have this anal retentive personality and they don't want to part with their stool, and that's the way they've been all their lives. Dame Cicely Saunders, who's the founder of the modern hospice movement, used to tell her residents that the hand that writes for the narcotics and does not write for the bowel regimen will be the same hand that will disimpact the patient at 3 o'clock in the morning. And that's a good motivator. So every time I write for narcotics, I remember her words. The drug of choice is Senna. Senna is cheap, it's over the counter, it's an excellent stimulant laxative, and you titrate it to a daily bowel movement. We used to use Senocot S, which is Senna plus a stool softener. Recent data suggests that the stool softener actually makes it worse. So the patients do better with just Senna. And I don't care if they need 1 a day or 3-4 times a day, whatever it takes to move your bowels once a day. Again, our scumbag pharmaceutical industry is doing their best to define things that we didn't consider diseases and to come up with very expensive treatment regimens for those. And they don't care about the dead and dying. They're willing to prey on them just like everybody else. And so they have developed this new disease, and they're marketing it like nobody ever heard of it before. It's called narcotic-induced constipation. It's like, duh. And they've developed this new product, which is a narcotic antagonist, but it only blocks the narcotic receptors to the bowel. It's very expensive. It has to be given by injection. And they've got this big ad campaign, and they're marketing hospice physicians, and they're marketing oncologists. And I think some of the oncologists have been using it when you got a good solution to the problem already. And they've been chasing me around, and I thought I had lost them, but they found me the other day again. So don't be deceived. Senna works just fine. The other alternative is to use an osmotic. Lactulose is the one that a lot of people use. And it's basically just a non-absorbable sugar. And if you've ever not had anything to eat for 24 hours and drank 2 quarts of apricot nectar, you understand how an osmotic laxative works. You know, you sort of hug the, you kind of become very close friends with that porcelain throne for several hours. Sorbitol is actually cheaper than lactulose, and it's equally effective. And so maybe 15 to 30 mLs 1 to 3 times a day, again titrated to a 1 daily bowel movement. Problem I find with sorbitol is because it's a sugar, it's very sweet, and a lot of people say it makes them nauseated. Other people like it, but again, in terms of, it's kind of dealer's choice, just whatever they need to have a daily bowel movement. We talked about the study comparing Senna plus Colace to Senna alone. Hard stool is mainly a problem of prolonged transit through the gut, and if they're getting a stimulant, the bowels, you know, the stool is moving through the gut, and so they tend not to need a stool softener. I would only use that if people have pain on defecation, if they have hemorrhoids or anal fissures, and it hurts, you know, and they have bleeding. Hiccups sounds silly, but a lot of people suffer terribly with hiccups at end of life, particularly if they have malignancies that are tickling the diaphragm and causing uncontrolled hiccups. Pro-motility agents like Reglan can be very effective to control hiccups. Haldol is also a good choice. Again, if you remember, our concept is to try to use as few drugs as possible, and if we can use one drug to treat many symptoms, that's better than using several drugs to treat one symptom. So it depends on the clinical situation. So a patient is a diabetic and has gastric stasis, and they also have hiccups, well, Reglan would be a great choice because there you got a twofer. You got one drug that's going to treat 2 different symptoms. Likewise, if the patient has other kinds of nausea or if they have agitation and they have hiccups, well, Haldol might be a good choice because, again, you're going to use one drug to treat several symptoms. Anorexia. Weight loss is part of the natural decline and disease process, and often just counseling will deal with the problem. Very often, again, as we talked about earlier, it may be the family that's very concerned because they're not eating. It's bred into all of us since we were little rugrats that food equals love, and if somebody's losing weight, then you're not loving them enough, and so they chase you around with a spoonful of mashed potatoes, like my grandmother used to do with me when I was a little boy. Eat, eat, eat. I can still see the spoon coming at me. But sometimes you can make people feel better by adding steroids. Steroids kind of make you feel good overall, make you hungry, can increase your appetite. Works fine for a week or two, and then you start getting all the steroid side effects with insomnia, agitation, pimples, and cushingoid appearance, so people start liking their steroids less. Reglan can sometimes stimulate the appetite. Agitated delirium. Again, emphasize treating the reversible causes, but I think first we need to come back to look at what's happening as this patient is becoming agitated and delirious. Saw a patient at Hospice at the lake not too long ago, and as I was talking to him standing by the bedside, he was talking to the person standing next to me, and there was no person standing next to me, and it was a relative who had passed away. And they were having a pleasant conversation. That's a common part of the dying process. It actually is giving them comfort. You don't want to treat that. It's what our chaplains call the journey language. So you want to make sure. Now, on the other hand, if there are monsters coming in the window, then that's terrifying them, and the patient is therefore suffering terribly from that, and that's something we want to treat. So decide what kind of delirium the patient is having before you decide whether you want to treat it. And again, start by looking for reversible causes. An enema or a Foley catheter may well cure their agitation. Contributory drugs are a big problem. Steroid psychosis is very common. Anticholinergic drugs. The tricyclic antidepressants have a significant anticholinergic effect and can cause terrible agitated delirium. Scopolamine patch that you might be using for nausea can cause terrible agitated delirium. So get rid of those contributory drugs. The drug I have the biggest fight with, and although I love my nurses, the ones we fight with the most about this are benzo drugs. Ativan, Xanax, that whole category of drugs. There is paradoxical agitation that occurs fairly commonly with these drugs. And people think, well, if you're agitated, take a chill pill. So if you're going to have one of these paradoxical responses, what happens? You give them their Ativan, and they get more agitated. So at 3 a.m., what do? You call the doctor on call, and half asleep, he agrees to your wanting to double the Ativan, and then they get more agitated. And so they're just caught on this upward spiral. And you need to recognize that this is a drug reaction, and you need to get rid of the benzo drugs and switch the patient to something else like Haldol. This paradoxical reaction is terribly underdiagnosed. If the patient truly is suffering from their agitated delirium, we need to treat them. The drug of choice is haloperidol. Again, we had a patient at the lake a few weeks ago, was transferred from our home hospice service, was agitated, was violent, had punched his wife in the nose, had punched his hospice nurse, and so I go into the room with one of the nurses at the lake. She's got 5 milligrams of Haldol in a syringe behind her back. I get to talking to the guy, and as soon as he looks away, he gets 5 milligrams of Haldol sub-Q, and then we both ducked as he swung at us. In about 10 minutes, he was really chilled out. And Haldol is a nice drug, again, because you don't sedate them, you don't have to knock them out, but you can really chill somebody out pretty quickly. If they're not responding to Haldol, or if you need some time for that drug to work, midazolam, which is Versed, is a good drug because you're going to put somebody out for an hour or two, and give everybody a chance to recover from their bruises, and give these other drugs a chance to work. Even Peninsula Regional has developed an agitation protocol. And the temptation in institutions is not to, sedate some of these people, and their response is generally to put restraints on them. I hate to use restraints. We have never, since our inpatient facility opened, physically restrained a patient because they can be made comfortable with drugs. And if you're agitated and you're paranoid and you think people are out to get you, and they strap you down, well, that just reinforces your opinion that they're out to get you. Depression, the psychiatrists, have this coding manual, and it has gotten bigger and bigger and bigger over the years, to the point that you can conclude that we're all crazy, and that there's a diagnosis in there for every one of us. And they're beginning to change their views on that and realize that some situations are appropriate, and I think depression is one of those. Depression is not just necessarily sadness. Depression is really sadness that's out of proportion to what your clinical situation is. So if everything is going great in your life, your family and your job and all the things that give you measures of success are going well, and you're sad and you don't want to eat and you can't sleep at night, that's depression, because that's out of proportion. But if your spouse just died, well, the sadness can be a normal part of a grieving process. And so patients who have life-limiting illnesses, we need to be careful that we don't overdiagnose and think that we need to make everybody happy. I actually worry the most about somebody that's been given a life-limiting diagnosis and they're all giddy and happy. That usually means they're going to go home and blow their brains out. So we need to think a little more about depression and think who we want to treat. But if we do decide that treatment is appropriate, and often it is, we have to realize these people are at the end of their lives, and we don't have months or years to gradually adjust medications. We need to get them comfortable fairly quickly. And an approach at end-of-life situation that's really not used for depression anywhere else is to give them a psychostimulant. The equivalent of like getting 15 cups of coffee IV, and Ritalin is the drug of choice when we want to use the psychostimulant. This will really get you wired, and it'll cause a lot of insomnia, so you want to give it in the correct dose, and you want no medicine after noon. If it's a little old lady, you might even just want to give her 2.5 milligrams just once a day, first thing in the morning. But certainly 5 milligrams twice a day with a second dose no later than noon if you're going to use a psychostimulant. Steroids we talked about a little bit earlier. Steroids make you feel good, give you energy, they increase your appetite. The longer you take them, the more side effects you get. So I don't like to use steroids at end of life unless I think the patient only has a few weeks to live and they need some treatment for depression. Difference between prednisone. Prednisone's a little cheaper, but it has more mineralocorticoid effect. So it's going to cause more sodium retention, it's going to cause more edema. So if there's no problem with edema, prednisone is the better choice. If the patient does have problem with edema, if they have congestive heart failure, then I would probably use dexamethasone because they're going to get less edema from that, or less likely to get edema from that. There's the selective serotonin drugs like Prozac, are a fine choice, particularly if we think they probably got a month or two to live and they're going to benefit from antidepressant drugs. Anxiety and insomnia. Most insomnia has non-physical causes, and at end of life, very commonly people are concerned that if I go to sleep, I'm not going to wake up, and so I'm going to try to stay awake all the time. Again, coming back to my favorite industry, which is the pharmaceutical industry, they market these products. This is Lunesta, Ambien, that whole category of drugs. Large randomized studies have shown that these drugs give you about 20 minutes extra of sleep per night, and particularly in chronically ill and elderly people, daytime drowsiness and falls go way up. I think if you put that on the scales, these drugs are actually futile and cause more problems than they gain. I think they should be avoided. So that being said, it's very hard to convince patients and physicians not to use those drugs. Some antidepressants can cause some sedation, and so if depression and insomnia is a problem, then using some of the tricyclics like nortriptyline and give the entire dose at bedtime is a good way to, as a sleeping pill, and also to treat their depression. Benzo drugs work fine. I tend to think of benzo drugs in people that have already taken them and are kind of comfortable with them, and we're pretty sure we're not going to get a paradoxical response from. But if they have a chill pill like Ativan, and they're taking maybe 0.5 once or twice a day, tell them to take a milligram, take 2 pills at bedtime as a sleeping pill. Antihistamines like Benadryl, cheap, over the counter. 50 milligrams of Benadryl at bedtime is a very nice sleeping pill. Take it with a glass of wine if you need to. Dyspnea, shortness of breath. All narcotics are excellent to treat dyspnea. The one narcotic that has actually been looked at in controlled trials is morphine. And so if the patient just has problems with dyspnea, morphine is a good choice. The big fear people have is, and nursing staff has, that it's going to depress their respirations and cause people to stop breathing. People at end of life with severe chronic lung disease, congestive heart failure, cancer, what have you. Again, good science has been done. You don't shorten these people's lives. You merely make them feel better, and they live approximately the same length of time. All the other narcotics are equally effective anecdotally to treat dyspnea, but haven't been looked at in controlled trials. My approach is, if somebody is on a narcotic for other reasons like pain, I will tell them to go ahead and increase it or to take PRN doses for their dyspnea. If they haven't been using any narcotics at all and their only symptom is dyspnea, then I would probably start them on morphine. But if they're taking methadone, for example, already for pain, I would tell them to use a PRN dose of methadone for pain or dyspnea. Sometimes anxiety is a significant contributing factor, and so use of a chill pill will often help with their dyspnea. If they're not hypoxic, oxygen isn't going to benefit them, but certainly if they are hypoxic, if you see evidence that they're cyanotic, or if you've checked their oxygen saturation, it's below 90%, then giving them some oxygen is going to help. May be an issue at rest, may be an issue with exertion. Some patients may be comfortable at rest, but they get real short of breath with minimal exertion, and you do a pulse ox and you find that it's fine at rest, but once they walk to the bathroom, they desaturate. PRN oxygen is a good choice in that situation. Corticosteroids, part of the dyspnea may be bronchospasm, and steroids will help with the bronchospasm, particularly when you listen to their chest and you're hearing wheezing. Likewise, other bronchodilators like albuterol, little neb treatments may help their dyspnea depending on the clinical setting. Something that we have done and has kind of come into the hospice literature in the last year or two is to nebulize Lasix. And we give Lasix orally or intravenously, and what it does is it moves water across the tubule and the loop of Henle in the kidney and increases urine output and helps get rid of generalized edema. Well, inhaled Lasix moves water across the alveolar membrane. Doesn't get it out of the body, but it gets it out of the alveoli. And so if somebody has congestive heart failure and they've got a lot of crackles, then having them inhale Lasix, we give them just the injectable Lasix, 20 milligrams and a few cc's of saline, can be very effective in relieving dyspnea, particularly at end-of-life settings. Kind of a creative new idea. Cough. The best cough suppressant is a narcotic. Typically, cough medications have codeine. A lot of the stronger ones have codeine in them. All narcotics are equally effective for cough. Codeine is particularly constipating, so I don't know that it would be my drug of choice, but I would use one of the other narcotics. Again, if they're already taking a narcotic for some other reason, they can take it PRN for cough. If they're not taking any narcotics, I would probably start them on small doses of morphine, because it's a short-acting drug and you're not going to have to deal with it for more than a few hours when it'll be out of their system. A new treatment, and we have just ordered some of this, we're getting ready to start, for people that truly have refractory cough, is to nebulize lidocaine. And they nebulize 5 mLs of 2% lidocaine, and it very effectively, very quickly stops their cough. The problem, obviously, is that it anesthetizes the throat, and the danger is that they're going to aspirate. And so we require that if we're going to do this, that we're going to keep the patient upright and no food or drink for 40 minutes after we've given them one of these lidocaine treatments. Seizures. Ativan is a very effective anticonvulsant. Versed or midazolam is a very effective anticonvulsant as well. Very often we are confronted with a problem, people that have seizures, perhaps from brain metastases or from underlying seizure disorders. They're near the end of their life, they can no longer take food or drink, and they're on oral Dilantin. We can't use the Dilantin anymore because they can't swallow. Dilantin can be given intravenously, but it has to be given very slowly, and it's technically difficult, and you got to maintain venous access, which you might not want to do at the end of life. So another alternative is to switch them to phenobarbital and to give that subcutaneously. You can give some of the medications by rectal suppository. I'm not a big fan of using rectal suppositories at end of life because just of the the personal indignity, and I think a lot of people don't like something put up their backside. Infections, we need to think about whether we want to treat the infection or not. If our goal at end of life is comfort, then treating an infection may or may not be appropriate depending on how long they have to live and how much symptoms the infection is causing. The patient has recurrent bacteremia, and it's realistically we're not going to cure that infection, then giving them intravenous antibiotics may be futile. We would just want to give them some corticosteroids or acetaminophen to control their fever. Likewise, we have this attitude that all fever represents infection. Very common for people with advanced cancers at the end of their lives. The cancer itself will cause fever, and there's no infection at all. And so maybe we want to do is to recognize that this patient doesn't have an infection, they just have cancer-causing fever, and we need to decide if the fever is causing symptoms, and maybe we want to just treat the fever and not risk antibiotics. Likewise, antibiotics can cause fever. And so another mistake is we keep switching from antibiotic to antibiotic because of persistent fever, and in fact it's the antibiotic that's causing the fever. If we do decide to use antibiotics, drugs that have low toxicity are inexpensive, and Cipro is a good choice. Nystatin is a drug we commonly use at end of life. Good treatment for oral candidiasis. Can be a good treatment topically for candida infections. Flagyl or metronidazole is an excellent antibiotic to use to treat anaerobic infections. And the clinical characteristic of an anaerobic infection is it stinks. It just stinks beyond description. If you've got an anaerobic abscess and you've ever been in the room when the surgeon lanced it and the pus came out, everybody in the room drops to their knees and starts gagging within seconds. So you know you're dealing with an anaerobe. Where we see anaerobic infections that's problematic are people with locally advanced uncontrolled breast cancer, where the whole chest wall is involved with the cancer. It's spreading around to the back and down the arm. It basically looks like raw hamburger that's oozing this horrible foul-smelling pus. We're not going to cure that anaerobic infection that's all intermixed with the cancer, but if we can partially treat it, we'll often control the odor. And so giving those people topical Flagyl, or Flagyl also comes in a gel form for topical administration called Metrogel. That may be a good choice. Terminal secretions, the death rattle. This is usually patients in the last day or two of their life. They are so weak, they are so debilitated, they're generally unconscious at this point that they can't handle their saliva, and they have secretions in the back of their throat and in their trachea, and it rattles around every time they breathe in and out. Drives families up the wall. Patients probably aren't aware of it, but it's worth treating just to treat the family. And when we got somebody in the last day or two of their lives, we need to think about that, we need to anticipate that. Need to listen over the trachea to see if you hear some rattling secretions and treat it early. And the treatment of choice is to give them an anticholinergic to dry up the secretions. Ophthalmic atropine, which is a 1% solution, giving them a drop under the tongue hourly as needed, is a very effective way to treat this. And again, the earlier we start it, the more effective it is. Some pharmacist drives them up the wall because this is for the eye, and since it's prescribed for the eye, you can't give it any other way, but of course you can. A scopolamine patch is very effective as well. That's going to take a little while. Sometimes I'll prescribe both so they can get use the drops under the tongue for a few hours until the patch starts to kick in. This is like leaning into a left hook, which the sort of things you shouldn't do is to position the patient in the left lateral decubitus position, because the left main stem bronchus comes off at a right angle, And so what you're going to do is to cause all those secretions to drop down into the bronchi and to pool down there. And if you're trying to save somebody's life, you absolutely don't want to do that. But if this is an end-of-life situation, if you can move the secretions out of the trachea down into the smaller bronchioles and the alveoli, you get rid of the rattling symptom. The patient's going to pass away fairly quickly, whether you do it or not. So this can be a very effective way to help get rid of these secretions as well. What you absolutely don't want to do is to suction the patient. If you've got somebody that's unresponsive, they're going to die in the next day or two, they are perfectly comfortable, and you've got an agitated family because they're making these noises, and you stick a suction catheter down them, then this patient is going to get agitated, and you're going to add to their suffering, and not only are you going to have an unhappy family, you're going to have an unhappy patient too. So you should not be suctioning patients at the end of their lives. And that is the end of my talk, and I'd be happy to answer any questions. All right. Thank you all very much. See you next time.